Native high-resolution T2 weighted images, T2WI, are essential for morphological differentiation of pelvic organ tissue. Contrast-enhanced T1 weighted images, CT1WI, give important additional information in almost every problem and should be therefore routinely performed. However, kidney functions, creatinine, should be checked before the intravenous application of contrast media. In recent years, diffusion-weighted imaging gains more attention. This imaging technique was designed to depict alterations in thermally induced random, Brownian motion of water molecules within tissues and the degree of this motion is known as diffusion-weighted. MR imaging, DWI, can be performed quickly, without the necessity of contrast IV. The technique yields qualitative and quantitative information about cellularity and cellular membrane integrity. High cellularity and cell membrane integrity restrict water mobility and therefore diffusion. Tumors. During MR performance, diffusion sensitivity can easily be varied by changing the B value used during image acquisition. For gynecologic malignancies, B values up to 800 to 1000 are recommended for local tumor staging and the evaluation of lymph node affection. Quantitative analysis of diffusion may be performed by obtaining and mapping apparent diffusion coefficient (ADC) values. This technique can be performed in patients with contraindication for contrast IV, which is of great benefit for further evaluation in case of tumorous. For lymph node detection, a native T1WI sequence or proton-weighted (PD) sequence is helpful. Computed tomography (CT). With a multi-detector CT, MDCT, the examination of a region of interest can be performed in axial plane in a short examination time with sub-millimeter resolution. The raw data can be post-processed in any plane with approximately the same resolution. It should be noticed that intravenous contrast application is essential for soft tissue contrast, because even CT in venous phase has less tissue contrast compared to native MRI. Before perform contrast-enhanced CT, CECT, kidney function, creatinine, and thyroid function, TSH, FT3, FT4, should be checked to be with normal values. Endometrial cancer. Regardless of hormone status, the normal endometrium is always hyperintense in native T2W images. The junctional zone is hypointense and the outer myometrium is of moderate signal intensity. Endometrial cancer is moderately hyperintense in T2WI. However, small tumors can be isointense in regard to the endometrium and may be therefore difficult to detect. Sequence with fat saturation is therefore recommended, as the tumor then represents hypointense compared to the myometrium. Best delineation. Approximate 2 minutes after contrast media injection. Diffusion-weighted images may also be helpful for tumor detection, as this shows a stronger signal decrease in ADC map than the surrounding normal myometrium. The lack of the fat layer between organs, best seen in the native T1WI, as well as a thickened bladder or rectal wall, are an indicator for a beginning infiltration of the bladder or the rectal mucosa. Staging is done using UICC criteria, Union Internationale contre le Cancer, the most recent version, dating to a CT examination, is not used for local staging. However, it is used for radiation planning or for complete staging for distant metastases, especially pulmonary, HEPAR, retroperitoneal lymph nodes, performed for another indication. An endometrial cancer represents as a hypodense mass in the endometrial cavity. The evaluation of the depth of myometrial infiltration with CECT is made more difficult due to the low contrast of soft tissue, as sensitivity is only around 58 to 61%. If the cervix is heterogeneous and thickened, suspicion of infiltration must be filed. If a tumor expands beyond the serosa. A blurred reticular streaking can be expected. A bladder or rectum infiltration is to be presumed when the fat layer is missing. When solid tissue expansions in the lumen can be proven, an infiltration is the case. The Peru time/central time has a standing in the diagnosis of distal metastases and in the diagnosis of recurrent disease. Cervical cancer. The decision for primary surgery or primary combined chemoradiation or brachytherapy, respectively, is based in particular on tumor size and the discovery of an infiltration of the parametrium. With the expansion of cervical cancer along the parametrium to the pelvic wall or to the lower third of the vagina, the probability of positive paraortal or inguinal lymph nodes grows. Metastases in the liver, the lungs or bones could exist in the advanced tumor stages. For this reason, a complete cross-sectional imaging-based staging including MRI of the pelvis and CT of the body and chest is recommended before treatment. Ultrasound is often not sufficient for a complete evaluation of a local finding. However, this technique is used to exclude hydronephrosis or liver metastases. In MRI, the mucosa of the normal cervix represents hyperintensive in the native T2WI, whereas the cervical stroma is hypointense. Cervical cancer represents hyperintensive in the native T2WI in relation to the hypointense stroma tissue. If the cervical stromal ring appears intact on T2WI on transverse oblique plane, parametrial invasion is present in 0 to 6% of cases. In a large meta-analysis by Riggin et al., the authors found an overall sensitivity of 66% and a specificity of 84% for detection of parametrial invasion in 1341 patients using 1.5 T MRI. In rare cases, the tumor is isointense to the surrounding tissue in the T2WI or too small in diameter, as this may be residual tumor tissue after curettage. In these cases, DWI or CET1WI with fat saturation is relevant for tumor detection. There is a signal decrease on ADC map and a hypointense signal in early phase after application of contrast IV in T1WI with fat saturation compared to surrounding tissue. Best delineation will be reached 15 to 30s after contrast injection. In late phase, however, the tumor represents hyperintense compared to uterine myometrium. Dynamic contrast. Enhanced sequences are therefore recommended. The staging for cervical cancer is done according to UICC criteria, Union Internationale contre le Cancer, the most recent version dating to. While the intravenous application of contrast IV can be foregone during primary detection as the tumor is easily detectable in the native T2WI in most cases, such an application is compulsive for therapy control after brachytherapy, after combined chemoradiation or after surgery to differentiate between a residual tumor or scar-like changes. The CT is not necessary for primary diagnosis but is used for planning radiation or detecting distal metastases, lungs, liver, bones, or peripheral lymph node metastases. In case of a contrast media-enhanced CT, cervical cancer usually represents as a thickening of non-centric cervical tissue with a diameter of more than 3.5 centimeters. Parametrial involvement is probable if cervical borders are blurry, thickened and spiculated. An infiltration of the bladder or rectal wall represents in an irregular uterine sarcoma. Uterine sarcoma can be classified into three histological subtypes: leiomyosarcoma, commonly myometrial origin, endometrial stromal sarcoma, and adenosarcoma, commonly endometrial origin. The transvaginal ultrasound is used as the primary standard image modality. In addition to this, MRI offers relevant additional information about tumor expansion. The CECT provides an overview of the infiltrated surrounding structures, distant metastases, ascites or peritoneal implants. The Peru time/central time offers Promising possibilities for staging, grading and therapy control for sarcomas. All in all, differentiating between leiomyoma and leiomyosarcoma is challenging by using MRI. Apart from a fast growth, a large heterogeneous tumor, hypervascular foci or central necrotic components can be indicators. Endometrial stromal sarcoma commonly represents an infiltrative mass with cystic parts. The endometrium, as well as the myometrium, is involved. Leiomyosarcoma, however, is mostly shown through heterogeneous signal intensity with a fuzzy boundary. Commonly, at least 50% are hyperintense on T2WI, with additional hyperintensities on T1WI. On CECT, the uterus commonly presents as a heterogeneous mass with ill-defined boundaries and irregular central zones, commonly due to necrosis. The adenosarcoma is often defined as a large, multiseptated, cystic mass with heterogeneous solid components in the uterine cavity. The solid components are mostly hypointense in the native T2WI, which represent with strong contrast enhancement in CET1WI. Adenosarcoma may also presents as a large polypoid mass occupying the endometrial cavity, possibly protruding into the vaginal cavity. Staging is done according to UIC criteria, Union Internationale contre le Cancer, the most recent version dating to uterine lymphoma. Non-Hodgkin lymphoma of the uterus and the cervix are very rare, less than 1%, and may affect women between the ages of. Local tumor detection can be undertaken by using ultrasound. However, in some cases the entire extent of the lymphoma cannot be depicted, so cross-sectional image modality may be useful. If there is already a clinically based suspicion of a tumor extent beyond the small pelvis, a CECT of the abdomen for therapy planning and for follow-up examination should be initiated for the visualization of local findings. Contrast-enhanced MRI of the pelvis ought to be the image modality of choice. Using MRI, uterine lymphomas are mostly visible as homogeneous, hyperintense masses in native T2WI, without a clear differentiation to the surrounding tissue and with a strong enhancement. After contrast application. Recurrent tumor disease. Recurrence of endometrial cancer after primary surgery mostly occur within the first 2 years. Metastases can be found as solid mass within the vagina and the perimetrium, or as lymph node metastases. Recurrence of endometrial cancer after primary radiation therapy can often be found within the uterus or the ovaries. For local recurrence, MRI is the cross-sectional imaging modality of choice. However, if there is suspicion for distant metastases, CECT gives a better overview and is commonly performed for the chest and the body in one examination. Recurrence of a cervical cancer is seen in approximate 10 to 42% of primary surgically treated patients. They often show as a solid mass at the vaginal vault, but can also manifest themselves within the vagina, the perimetrium, the pelvic wall or the bones if there is a clinical suspicion of tumor recurrence in the entire pelvis. Contrast-enhanced MRI for detection and diagnosis of its extent is relevant. The differentiation to scar tissue is especially important. Scar tissue as well as residual tumor tissue shows as moderately hyperintense in native T2WI. For differentiation, the CET1WI is used. Scar tissue is hypointense due to missing enhancement. Inflamed/tumorous tissue mostly absorbs contrast media and represents hyperintense. It is to be mentioned, however, that differentiation may be challenging in between the first 6 months due to contrast enhancement of fibrous scar tissue.